the restaurant scene.
Inner workings of the restaurant scene of Indianapolis.
Fair enough.
Big deal.
It's a pretty big deal.
It was a big deal.
Monday night hopping.
Yeah, it was. Yeah, it was. Can't believe it's Monday.
Yeah.
Man, can't believe it's. Well, that was the most, or from an information distribution perspective, from an expertise perspective, even though I will say it was an intense information dump, that was by far the best conference I've ever attended. It was the panel of experts.
Both panels.
Both panels were incredible. Gloria and team put on just an amazing conference. It felt great.
It was very nice.
Like the food was good.
Everything was good.
The environment was, I felt welcome. I felt special. That's what you want when you go to a conference. And it was not too big. It was like the right amount. It was probably 700 total guests, but 200 in person. You said like 500 digital. I love that they put it out. All of the virtual content's out. All the virtual content is out for free for everyone. The decks were available as soon as it started.
And the AG was very smooth. Everything was very smooth.
It was just so well done. So
very well
just kudos to the team, to the National Healthcare Price Transparency Conference team. We were incredibly impressed. We were honored to be a part. Thank you for letting us be a part. And all of us worked to fight to make the financials of healthcare in this country work better.
That's what everyone's trying to do.
And that's what everybody's trying to do from all these different perspectives. And it was really great to hear all the different perspectives. We had the employer perspective was there. The provider perspective was there. The consulting perspective was there. Everybody's trying to attack this. We had a whole breakdown from an accountant's point of view, looking at how money moves through the organization. And I think one of my favorite slides was the hospital ownership diagram. Because it literally is insane when you look at it. It was like 36 different entities and shadow organizations. It was wild just seeing. It's like, okay, and these other small organizations having a tax benefit from the larger ones, but I don't know, it was just kind of wild.
Yeah.
They ended with some takeaways. There was a lot going on. We'll get into it. We'll get into it during the pod, but they ended with starting with market strategies as their number one takeaway. And that was around just being able to get the data. People are still not all getting the data, but it is out there. We provide it. Others provide it. We don't care. Just go get it from somebody. Please.
Get it. Yes, go get
it. Get it, use it, align payment, and demand accountability. And I think that's accountability from an employer perspective, from the CEO perspective, from the HR perspective, wherever you get that function. I know Mark Cuban talked about having it within HR, having a chief benefits officer, whoever you in the C-suite is working to ensure that your organization is holding the insurance companies accountable. If you are, and after this conference, I really think it's maybe the only way in the future. If you are direct, if you're employer funded, and you're just directly contracting with the care delivery organizations, which seems like that's starting to make more and more sense.
It's becoming more feasible. I think
more feasible
with more technology.
But either way, you have to get into the detail of the data. You need to look at these claims from like double billing to
fraud,
upcoding is a form of fraud. All of these different things. I mean, it's really, really important. So market strategies.
I'd say the main message was probably throughout that was consistent was that these employers have a fiduciary responsibility to their employees.
Yes.
To be getting their hands on this data.
Yes.
And to be getting an understanding of what pricing is supposed to be, because at some point, early on in the cycle, their healthcare dollars are coming out of their wages.
Right.
And they're coming out of the company's bottom line.
Right.
So you're actually doing not only yourself, but all of your employees and all of your stakeholders and shareholders potentially for public companies. You're doing them a disservice by not having all of this information available to you.
Yeah, huge disservice.
That seems to be the kind of overarching theme of most of the sessions.
I agree. It was said multiple times, and it was something you don't hear. That's not something you hear right now.
And you might not think of it like that. It's like, healthcare, that's what Mark Cuban said, like healthcare is probably one of your biggest costs behind payroll, if not the biggest cost behind payroll.
Nobody's looking at it as something that they can actually affect.
Right, like this is what it is, but it's not what it is.
Right.
If you have the information, and there were tons of examples today.
Yes.
Of instances where people were actually properly fighting high claims and high billing amounts and things like that, and saving their organizations
millions,
in some cases, millions and millions.
It was
of dollars.
almost always millions.
Yeah.
This one, I can't remember Purdue. Was it Purdue that said they saved $25 million over 5 years? Yeah. Insane. $25 million over 5 years for their employees and for their organization.
Yeah. And their students and the, it goes back into the system. There was also some perspective of like, that's $25 million that's coming out of the pocket of the providers.
Right. Yes.
In some cases, but, so there's somewhat of a community, but this is the system that was made. It's not ideal for anybody, but
and everybody knows there is huge operational efficiency within a large hospital. Everybody knows that the hospitals know it. They work on it. They acknowledge it. But hopefully they were able to adjust to that $25 million shortfall quickly, and figure out what to do about it. But I think it's important. It's also really interesting from Chris Whaley, from his study and all of the information that healthcare organizations' quality scores are not correlated with price.
No, there's like a 0% correlation.
And that actually makes sense to me. And so it's really interesting. People are like, well, let's look at quality. And yes, we understand that if you're negotiating with a payer, quality is going to be a lever, and probably an appropriate lever, right?
If anything's going to be a lever, it would seem to be quality.
It seems like that would be the
best lever, but it doesn't seem to actually, because there's also years and years of time. And this is over time. You get maybe the best doctor or the best doctors, but then your staff sort of turns over.
Yep.
They go somewhere else. So your quality at one point is not the same as it is now.
Right. While it is a negotiating lever, it is not what these negotiated prices are based on. This is layers and layers and years of inherited contracts and precedent, and the fact that your organization has the most providers wearing your jersey, and that is where the negotiating leverage in the end of the day comes from. And a lot of times nobody really knows why these prices are the way they are.
No, that's why everybody we talk to is surprised when we're showing them their data and their competitors. It's always like, why are they getting paid that much more? We're a better hospital. Well, we don't know that, but I mean, the answer is probably not because it's quality. Yeah, quality of care.
You just have better focus, or they're a better negotiating team.
Better negotiating team, or maybe they just maybe they focused on those specific procedures in their last negotiation. Maybe you're doing better in other areas, or but that's where it's up to you to find out what are your high volume procedures that you're doing. Negotiate better rates there.
Yeah. It was really good. Man, I learned so much. Takeaway number 2, policies to increase transparency. So they first talked about the market strategies. And then for policies to increase transparency, number 1, price transparency, near and dear to our hearts.
Sure.
Number 2, data transparency, right up our alley.
Yeah.
Quality transparency.
That we need more of. We need more of. Better quality metrics.
Yeah, quality metrics, getting those, exposed, and within the same kind of analysis that you're looking at the price transparency data, because it does matter, even though, as we just talked, it is the numbers say that it is absolutely not an influence for the prices as they are today. Doesn't mean they can't be an influence for the prices of the future. Ownership transparency, and this is where they had that wild slide. Let me actually pull up who did it. So it was Marilyn. I love her. I kept calling her our queen, and I agree. She is the queen. She was the queen.
She was.
So Marilyn Bartlett, CPA, brilliant, and just a shining light. Just seemed like a just amazing person. But I'm just going to pull it up. She Parkview Health. It's a health system in the Indianapolis area. It's a little bit north of Indy, and probably looking here, 20 to 30 different entities made up of not-for-profit hospital, which that was another funny thing, saying, hey, we probably shouldn't say not-for-profit hospitals. They are for-profit hospitals.
They're just tax-exempt.
They're tax-exempt hospitals, which I thought was funny. Not-for-profit entities that are not hospitals, for-profit entities, all within the same kind of umbrella, and joint venture and affiliates, right? Whether they're, some of these can be overseas. There's all kinds of interesting things going around, especially with PE influences, PE coming into healthcare. And disregarded entities. Frankly, I don't know what a disregarded entity is, but I hope they don't know they're called that. It could hurt their feelings.
could just be a defunct organization or something that was created for a purpose and is no longer.
Yeah,
perhaps.
Yeah,
but the corporate structures of these places are very interesting, to say the least, and it definitely potentially reeks of something more. Nefarious.
Yeah, it does.
I think was the insinuation there.
Yeah, agreed. I did like there was a gentleman on the panel, Sean Grimminger, and really seemed like just a brilliant guy. Just had so many nuggets. I hope I can talk to him again. I hope we can get to talk to him again. But one of the things he said was, PE firms. PE firms, are going to go into a broken market. So it's a good indicator. If they're jumping into this market, something
is broken and is fixable. I think it's
broken and fixable.
I don't know if he said that specifically, but it's kind of the implication is
both things.
There's something that is broken here, but can be fixable to make a lot of money.
Right.
Unfortunately, private equity tends to take that money instead of putting it back into.
They're going to take it.
Which is, you fix something, I guess. Yeah,
that's what they do. That is the model.
And he had a paper, I think, that he and some others collaborated on there was 10 rules for hospital negotiations.
We need to go find that.
But he had some good tips for
Hunter. There's another guy, Hunter Kellett, another gentleman, Hunter Kellett from Arnold Ventures, that seemed to know about this paper, but somebody mentioned it in the audience.
Yeah, and they had some good tips for how hospitals can negotiate, and just like kind of the objection handling and the false claims that the payers can make sometimes, that they lose money on Medicaid.
Yeah.
So that it has to be made up by the employer groups, but that's not correct.
Right.
That's a flat out fabrication.
Absolutely.
Most hospitals, if they're if they're run well enough, should be able to easily break even.
Absolutely.
On Medicaid.
Yeah, even a couple percentage points profit.
Yeah.
And Chris Whaley from Brown University, healthcare economics researcher, and really nice guy, brilliant guy. He was really nice. I had a nice conversation with him. Hope I can talk to him again as well. Proved it because he actually got the numbers, and looking at the Medicare rates nationally, they're close to break even. Looking across Medicare operating profit margin, the national average is negative 3.7%. But there are a significant number of organizations that are on the kind of right side of that zero margin,
right,
and are doing fantastic. So I'm sure there's things that can learn from each other, but that comes down to how they're operating their business,
right,
how they're operating their business and delivering care. They're doing it at a better, more efficient. So I thought that was really, really interesting. Really loved his analysis. Really thoughtful. He went over kind of rising hospital prices, driving spending growth, and showed kind of hospital services skyrocketing, college tuition and fees skyrocketing. Food and beverage was at an increase, which I've definitely been feeling that. So when I saw that, I was like, I believe in this chart because
yes.
because food and beverages and housing have definitely increased. And then kind of at the more affordable, where things have been flat or even gone down, new cars, household furnishings, clothing has been a little bit flat. Cell phone services have gone down. Computing software, toys, TVs have gone down. So it's kind of just looking at, that's from the source, is the Bureau of Labor Statistics, looking at that. And then he went into the fact that self-funding purchasers have a fiduciary responsibility to monitor healthcare prices. So he really set the tone for that.
Yeah, he was on one of the earlier presentations.
People kept kind of repeating that as they went through it. But I mean, with the back-to-back panels, one on policy, the other on how employers have that fiduciary responsibility to their employees and need to take control over healthcare cost, and that it is possible, and there's so many success stories. Those back-to-back panels, and then all of the other information. I mean, it's going to take me weeks to digest all of this info.
Oh yeah,
huge update also, and for all the listeners, to make sure you go check this out. So Sage Transparency 2.0 is released, and I was really impressed. And shout out to Gloria Sachdev for doing a live demo.
A live audience-led demo.
Audience-led demo.
With random call-outs of who wants to see what hospital.
Yeah, she said, call out a hospital. I was like, oh my God.
Very interesting.
Yeah, that was great.
And the developers at Quantify?
Let me check. That's amazing. Amazing memory.
Quantify
with a PHI at the end.
So yeah, met some of those guys. It's very slick stuff.
Yes, very impressive work. Shout out to the team at Quantify for everything that you've built, and for the one-a-days and twice-a-days with the National Price Transparency team, getting this data ready and putting it out there for people to use. So everybody go check out Sage, SAGE, transparency.org. You don't need a login. You just jump in, and they have exposed the data from a number of data sources, public data sources, including PT5 conducted by RAND. That's prices paid by employers and insurers. So that's really important. So employers and insurers specifically employers, have donated this data and shown what they are paying. So this is what employers are paying for their plans and to these healthcare care delivery organizations. NASHP is a hospital cost tool. It's got commercial payer mix, break-even cost, operating profit margin, which is really interesting. I love that they're not only looking at prices and from the employer spend and price transparency, but they're looking at the operating profit margin of the hospital. They're really looking at this in a circumspect way, which I think is admirable because this is a multivariable problem. It's highly complex.
It is. It's sort of hard to look at it in aggregate, but also hard to look at it in detail.
That's well said.
It's, so because there's not just one thing, but even if you're looking at things in aggregate, you're not, it's like, okay, well, we're not doing as well as this other hospital, but it would be very hard to then take that information and make it actionable. Okay, well then what? Well, we have 1,200 more employees in that hospital.
Mm-hmm.
or we have property taxes, whereas that hospital is not paying any because they're a tax exempt organization or whatever it is, right? So it's sort of hard to compare apples to apples. Just knowing, all right, my operating costs are not where they should be, I guess it's helpful in the sense of like, well, we got to figure out what we can do. And I think part of what this conference and people who are attending and speaking at this conference are trying to do is really piece together those different parts of the equation and identify what they are. And then, but we still need an overarching kind of strategy for how to improve operating costs. Right? Because if we provide price transparency data, that can definitely help you from a top line perspective get paid what you should get paid as a provider, right? Or as an employer, be able to see where your plan maybe you're quite overpaying for, or your employees are quite overpaying for services, right? As compared to other competitors that you may have. Right. So that's one aspect of it, but then there's also all of the administrative overhead, that's affecting your bottom line. There's the whole revenue cycle concept of how are you billing, how are you tracking people down, how many people are you going after? Right. Are you going after patients? Are you going after payers? Usually it's easier to go after patients.
Yep. And I mean, it's this really, care delivery organizations, especially large hospitals and health systems with a lot of money and a lot of really smart people, it can no longer be status quo to not understand the true detailed cost of care that's delivered. That is unacceptable in 2024 to not understand the labor, the supplies, the rooms, the operating overhead in a very, very detailed way, be able to control that and make things more and more efficient. There's also needs to be a better embracing of automation through automation and integration. Too often I see these healthcare organizations waiting for the vendor to figure out how to make their business better. It is your business. You figure out how to make it better. It is your fiduciary responsibility to make it better so that you can deliver better care to patients at a better price. And they talked about that too. Not only the fiduciary responsibility of the employer, but of the hospital. And what is that? And what do we think? What do they think it is? Right. So I thought that was really interesting. The other sources for the Sage Transparency data source, the quality ratings, the hospital star ratings, patient experience, and then there was some other proprietary sources from Quantos and January Advisors. So really impressive. Huge shout out to the team that worked on this, to Sarah Ott and Julie Reyes and Sarah Stewart and Lauren Vela, to Gloria for leading all of this. And who else? I'm missing one. I'm missing somebody to do the shout out. Kristen Royer. Amazing job. Michaela's great to see. Michaela's fantastic. Yeah, she's good. Thank you for taking great care of us, Michaela, and for all of the help up until this point. We were excited to see kind of our framework for how to think about and put price transparency data to work, kind of in the packet, along with a lot of other really great organizations that are all trying to help with this. And I think that was another good thing. Everybody there was truly a vanguard. The energy was amazing. They all care about this. They all want to make a difference. And I think there's a chink in the armor. They all believe that
it's solvable.
That it's solvable now.
They all believe it's solvable.
You don't always see that within healthcare and within these conferences. It can get a little bit jaded.
Yeah.
People throw up their hands. Yeah,
there is hope.
So,
which is important and critical. And maybe it didn't exist a little while ago.
I don't think it did.
With a lot of the legislation coming out, especially Senator Braun was there, right?
Yeah.
And he's co-sponsoring this price transparency co-spearheading with Bernie Sanders.
Yep.
It's an odd sort of couple there.
It was. They joked about that.
But I think there is this hope. They talked about this, kind of surviving 3 presidencies, starting with Obama, being then put actually into law by Trump.
Yeah.
And then being strengthened by Biden.
Right.
You've got kind of 3, some would say different people. Different presidents,
right?
Different strategies for sure.
Yes.
Kind of endorsing this and realizing that it's a major issue. But yeah, I think that there is definitely hope, and you don't get the sense that anyone is really trying to make a buck. I think that's that. There's not a get rich quick scheme here.
No,
it's very much
people have been affected personally.
Yeah,
their lives have been affected.
There are a lot of stories about individual people who are reaching out to these organizations and actually, who would otherwise be in crippling debt.
Yeah.
Based on these new laws and transparency laws.
Yeah.
Able to avoid that.
Cynthia opened us up, got everybody fired up, talking about stories of a woman who had a lien put on her house because she couldn't afford. I mean, this was a while back. I'm imagining. I don't think they can still do that now. There's some new laws in place, but this is something where nobody wants healthcare.
Right.
Nobody wants it. Nobody wants to be in the doctor office. Nobody wants to be in the hospital. Nobody wants to be under the knife. You need it. You don't even want it when you need it.
That is true.
So, I mean, these are people that their option is to either die or be severely debilitated. They have to get this done. And their choice is, you have to get this done. Your body is failing you in some kind of way. You have to get this done. But after you wake up, you might lose everything that you've had and have a horrible life.
Yeah.
And that's just not okay. And I've seen the health system up close, just personally with my wife and family. Somebody, one of the speakers was talking about, I forgot the story, but one particular person on the panel was talking about the fact that her husband had just gone through a serious surgery, and so I mean those are going to be huge costs coming up. But it was another person at the conference who was a speaker talking about the fact that she was kind of going through some regular procedures. MRIs. Over and over again, MRIs, and they were just kind of monitoring something. And then she finally got a call, I think from the insurance company. I don't know who she got the call from. I think the insurance.
From her employer.
Oh, really? From the employer? That would make more sense because the insurance company, I doubt they would do that. Yeah. So that makes more sense. They said, hey, if you go to this other provider, it's significantly less. I think she was paying for around $4,000 or something per session, maybe $2,000, maybe like $2,500 per session.
I think it was 36.
It was a 30. That's what I did that on purpose to get in the middle. And then I know for a fact that she got it down to 800.
And she got it to 800.
She got it down to 800. It's weird what I remember. She got it down to $800, and that's when that kind of put a bug in her ear. It's a weird analogy. To say like, hold on, like I need to figure this out. Why is this a thing?
Yeah, like is the quality worse? And it's like, no, the quality is the same.
Great.
And then she said the doctor was pretty upset to hear.
Yeah.
That he was referring all his patients to this thing that cost $3,600 for no reason.
Yep.
He could have been referring down the street to something that was $800, and then they ended up finding it cheaper and cheaper and cheaper.
Yep.
And this is what price transparency, I think, is going to end up doing ultimately. In some cases, we saw some increases.
Yeah, which will happen.
Which will happen
at the beginning.
But it's hard to tell if that's if it's because of price transparency. But I think over time, what the goal is, and that was another main theme of the conference, was transparency drives competition.
Mm-hmm.
And there is a major problem with competition.
Yes, it doesn't exist.
It doesn't exist in most of the country, unfortunately.
Yeah. It's all monopolies and walled gardens.
Yeah.
Corrupt. corruption in a lot of cases,
especially when it comes to hospitals and hospital systems. Now you could say like, okay, well, bigger hospital, more acquisitions, more resources,
and that's definitely what they do say,
and more ability to provide care to more people.
Right.
But as we know, bigger doesn't always mean better.
Yeah.
Often it comes with operational inefficiencies that are causing worse outcomes.
Yeah. And it's not sustainable. It's not sustainable. In these situations, you're creating no choice for people who can't afford your services. Your quality isn't necessarily kept in check. Prices are inflated on both sides. The hospital prices are skyrocketing. The insurance prices are skyrocketing. Profits are higher than ever. People are getting squeezed that, again, do not want healthcare, but will need it. And communities are not being serviced in a fair and equitable way. And we got to shine a light on it. And as Mark Cuban said, light is the best disinfectant. I don't know if that's actually true, but I know everybody says it.
Sunlight is the best disinfectant?
Yeah, that's what he said.
Yeah, I would think like bleach is the best disinfectant.
Yeah, right.
Right?
There's all kinds of things that can disinfect.
Maybe it is sunlight. UV light?
Yes, UV.
Least harmful disinfectant.
I'm going to look into this after the...
We should. If we're going to say it, we shouldn't.
What is actually the best disinfectant? I want something that can destroy everything. Truly disinfect. So yeah, it was wonderful. Thank you, everybody. Thank you for all of the knowledge being shared. Thank you for the earnestness, kindness, and openness in which you shared it. And thank you to the team who put this amazing conference together. We hope to be able to partner with you and help in any way we can in the future. And I think ending with Mark Cuban's words, take control of your destiny. Don't take anything the Bukas say as truth, and negotiate.
Well said.
All right. Thanks, Indy.
Signing off.